Hello, everybody. Today we are here to discuss some pediatric epilepsy syndrome, which is powered by Pediatric Hero Academy. But before we start, I would like to make some objective learning objective from our session. Today we are here to recognize a pediatric epilepsy syndrome, maybe special pediatric epilepsy syndrome, and how to interpret the EEG pattern and recall mnemonics for exam success. Apply knowledge to case vignette. First of all, we have I think seven cases, each case for a different epileptic syndrome, pediatric epileptic syndrome, and how we can discuss how we can interpret and the EEG for each one. Let's start with case number one, clinical scenario: a 7-year-old, 7 months old baby boy brought by his mother with notice a sudden cluster of jerk on waking up. The episode involved flexion of arm and the trunk, sometimes extension lasting for 1 to 2 seconds and repeated in bursts. Parent also note a loss of previously acquired milestone. He stopped rolling over and bubbling. Pregnancy and delivery was normal, but he has a history of tuberous sclerosis. Has ash leaf macules are present. So take care of uh, some bold words we are making to help you to build up your knowledge regarding this one. Has a sudden cluster of a jerk on waking up. It is involve flexion of arm or trunk, sometime extension lasting 1 to 2 seconds, and losing of previously acquired milestone. Moreover, he has a history of TS. What do you think? Okay, you're right. We are in West syndrome. Yes. Had I need from you to remember regarding West syndrome, an age group is coming from 6 to 9 months. Features is coming by salam attack and developmental regression. Don't forget this one. He has a developmental regression. And when we are seeing the EEG, we find hips arrhythmia. We'll show you what is the meaning of hips arrhythmia and the treatment ECTH, steroid or vagometering according to the causes and association. And just for mnemonics, that West syndrome, W for wake up spasm, and wave EEG worsening development. I hope I'm clear for this one. Moreover, I put all the specific pediatric epilepsy syndrome in one table in the end of the session, so you can compare and easily recognize and remember most of them. This is one video for infantile spasm or West syndrome to help you how to imagine the West syndrome is going on. Thank you for watching this video, and let us go for the next one. Details information regarding West syndrome or infantile spasm. It will be listed in the end of the session on one table for all specific pediatric epilepsies. Next one, we have the EEG, hips arrhythmia with high amplitude ketoic slow waves and multifocus. If you multifocal spike, if you look at EEG and find nothing, you cannot find anything characteristic for anything. You can see here there is more or less more spike everywhere in all lead of EEG, nothing specific, nothing characteristic. You are facing the hips arrhythmia. Okay, I hope I'm clear with infantile spasm or West syndrome, and we will go for the next case. And don't forget, we are making full detail for each syndrome in a table end of the session. Case number 2, a 3-year-old girl with a past history of infantile spasm now present with a frequent fall at nursery school teacher. Describe a drop, attack, and starring spell. Parent noted has intellectual disability and acquired special education. On, on EEG, has a slow spike wave complex at 2 Hz. I will give you few seconds just to can put possibility for this case. Okay, it is a Lennox-Gastaut syndrome. And here we have a different age group from 1 to 3 years and is accompanied by dropping attack, intellectual disability, or delay and multiple seizures. And we are seeing the EEG, it is about 2.5 less than, it is a slow spike wave. What does it mean? If you are making a tap on your disk, it is 2 time, you are tapping less than 2.5 time, like that, you are typing 2 time in 1 second. That does it mean by 2.5 hertz is a slow wave spike wave. Treatment have sodium valproate or lamotrigine plus or minus, and some recent text or researches help or intuitions that ketogenic diet could help, and mnemonic to put in your mind Lennox-Gastaut L for lots of seizure, low frequency spike, a learning disability. But it's most important, and you have never to forget to avoid the carbamazepine. It worsens the condition. Okay, I hope I'm clear so far. That avoid a carbamazepine which could worsen the condition. So features, we have a drop attack, intellectual disability, and multiple seizures, different seizures he has. Okay, and if we see the EEG, you can find what does it mean of slow spike wave, less than 2.5 hertz, which is diffuse. On EEG, spike followed by a slow wave repeating at a slow rate, less than 2.5 times per second, which is a diffuse, which means we have one spike followed by a slow wave spike and a slow wave which is slowly. And slowly, what does it mean? It means it have 2 point less than 2.5 time waves less than in less than 1 second. Okay, diffuse, it's not like a centrotemporal one, it is generalized all over the whole brain. It is generalized, it's spread across all brain, not only in one area. If you can check here in each lead of the brain, you will find this one. Okay, where it is clinically seen as slow wave in Lennox-Gastaut, or which is a severe type of childhood epilepsy, and this spatter is much slower than 3 hertz wave with absence epilepsy, which is will be included in our session today. I hope I'm clear. This is spikes all over, diffuse and slow Okay. So when we coming into comparison with absence epilepsy, you can differentiate between both of them. Case number 3, a 6-year-old girl is referred by her teacher. Okay, observed sudden pause in activity. Please take care. We have a sudden pauses in her activity. During a lesson, the child stares blankly. She is staring and make it rapidly. Then resume task as if nothing happened. As if nothing happened. Okay. Episodes last less than 20 seconds with no post-ictal confusion. Hyperventilation is a clinic is provoked in a similar spell, and when we do EEG, we show 3 Hz spike and wave discharge. I will give you a few seconds so you can find the bold word and you can uh, suggest what our clinical case. Yes, it is an absence epilepsy. Absence 1 is coming in a different age group. It is 4 to 10 years and make peak on 6 to 7 years with a feature of brief starring spell, eyelid flutters. Okay, EEG, it is about 3 hertz spike, which is not like the previous one. We are making 3 tab 1 2 3 in less than 1 second, wave spike, wave discharge, and I will show you an epilepsy 1 2 3. It's making a 3 tab as you are making a tab on your disk 3 times in less than 1 second. Treatment isoxamide, which is a first line. Absence epilepsy, isoxamide. Don't forget 3 A's for absence epilepsy. Absence epilepsy, age of 6, arrest of concentration or the child starring, arrest, and 3 hertz in EEG. Okay, and you have to remember that we must avoid the carbamazepine and phenytoin, which it came many times in a recall before and a call exam recall before. So don't forget we have to avoid the carbamazepine and avoid the phenytoin. What is the treatment of absence epilepsy? We are giving isoxamide, which is a first line of treatment. And we will, when we can see here the EEG, a typical 3 hertz spike and wave discharge, and if you can make a zoom and you will find one spike followed by doom, one spike followed with doom, which means wave discharge. One spike followed by doom, and 1 second we have a 3 in 1 second, 1 2 3 in 1 second. Appearance, burst of a spike and a slow wave complex repeating rhythmically at 3 times per a second. 3 hertz. What does it mean? If you can notice it all over, it run all over our brain distribution are generalized and symmetrically, and even in both uh, hemisphere. And the EEG clue, you are have a spike followed by a doom repeating regularly. I hope it is clear for you and have differentiate between the EEG for absence epilepsy and the non-hexagas 2. Okay, and when I'm making these cases or this few word, this is the most important word you have to remember or to memorize before you going exam, so you can put in your mind before you go exam, just to memorize this word. And if you have no time, you can go making revision of this quick word before going for exam. Case number 4, a clinical vignette. A 15-year-old boy present after dropping his toothbrush several times in the morning. Dropping his toothbrush several times in the morning. His parent also reported that he frequently spilled his breakfast cup, and has had one onset of generalized tonic-clonic seizures after staying up late for exam. On further questioning, he admits that has sudden jerk in both arms shortly after waking up. There is no developmental delay or no other focal neurological deficit. So, just collect your data and try to suggest our uh, So what could it be? I will give you a few seconds for this. Yes, it is a juvenile myoclonic epilepsy, Jan syndrome, which we have some very pathognomonics word we have for this one. Age group is coming from 18 to 20, 12 to 18 years old, and features come morning myoclonic jerk, dropping object. He are dropping his toothbrush, he is dropping his cup while breakfast in early morning. Okay, and we will making an EEG. We have a bilateral polyspike wave. 4 to 6 hertz is more rapid, very more rapid. We are making 4 to 6 waves in 1 second. Treatment here will be valproate and never to forget. And the first time in a specific pediatric epilepsy we are using valproate. We are using in another different epilepsy, but here we the first time to mention that we are using sodium valproate. My Jan's morning jerk adolescents need to lifelong medication, and it is a very important to stress. I need from you to remember that we are need a lifelong medication. Bilateral polyspike wave, lifelong medication, and we are using valproate and morning jerk and dropping object, which is a very characteristic. If you come here and you search for an EEG, it is a generalized polyspike. You can find here many spikes every lead of our brain, so it is a generalized and wave discharge a doom, and spikes was followed by doom everywhere in the brain, which is a hallmark finding in bilateral. Bilateral, not only in one hemisphere, it is in both hemispheres, symmetrical, 4 to 6 hertz polyspike and wave complex. The electrical discharge are seen diffused across the brain and often concentrated in frontotemporal or frontocentral region. Sorry for this, frontocentral region. I hope I'm clear for this one. You can find it easily in the exam, and you have a 4 to 6 hertz polyspike. It's not only one spike, you have many spikes, 1 2 1 1 2, and followed also by wave discharge spike, wave discharge spike, one wave discharge. And here, from here to here, if you can see or notice, we have here this is 1 second. Okay, and for easy to memorize, juvenile myoclonic epilepsy, we have a 4 polyspike, 4 to 5 hertz polyspike and wave discharge, 1 2 wave discharge, 1 2 3 wave discharge, which means 1 2 4 5 6 4 to 5 wave discharge, and followed by a doom or wave discharge. It is generalized bilateral, a brief, jerky or shock-like muscle jerk, especially in the upper arm up on waking up. I hope so. I hope so clear for this one. So we will go for the next one. Case number 5. A 7-year-old girl is brought by her parent after they noticed episode at night, where her jerk, her move, face, and drooling. She has a face drooling excessively. Sometimes she is unable to speak during the event, but remains aware. Seizures usually occur shortly after falling asleep, and she is otherwise healthy, performing well in school, and her neurological examination is normal. So, what do you think? I will give you another few seconds. You can suggest what this case. Yes, you are clear, which is a benign Ronaldic epilepsy, which is the very important in a pediatric specific epilepsy, and is very common in exam question and even in past test or on examinations or recall and even. It's an age group. It's coming from 3 to 13 years old, peak 7 to 9, feature nocturnal facial twitches and drooling and speech arrest. Nocturnal facial twitches, drooling and speech arrest, and it is a centrotemporal spike, which is a very characteristic and EEG, and usually it is a benign. What do you think is a treatment? Nothing, no treatment for this one unless it interfere with our daily activity. So treatment, there is nothing to be given, and only carbamazepine could be used if needed. Okay, this is which lead to our next slide. An EEG, a centrotemporal spike. We are starting from F73 T45 to 6, even till uh, F4 here, or I think less before C3. I think the end and G3 only specific area of the brain. It's sharp, tall wave. I cannot make zoom, but if you can make zoom, you can find it. A sharp, tall wave. Then flip up and down, which is a bivasic. I hope I can show you. It is a bivasic. I can make use this one. And laser pointer. Here it is down going up. Which will here go down, go up, go down, go up. Okay, and it's coming here and starting from the central temporal region from T3 to C3. You can localize this one, and by basic go up, go down, go up, go down in a specific area. And the EEG will not come alone, it come with a clinical scenario which it could suggest for you. Around central temporal part of the brain near the controlling the face. This epilepsy or this electrical abnormal electrical activity temporal occurring in central and temporal part of the brain near the area controlling the face, and EEG usually between T3 to C3 on the left on the matching the right side. When they show up, they become more obvious when the child is drowsy or going for a sleep. So I hope I can explain for you this EEG well and according to the previous case. So our next case, we have a 5-year-old boy who previously developing normally brought to the clinic because he has suddenly stopped speaking over the past 3 months. His parent describes that he can no longer understand simple command at home or school. He are not understanding anything. They first thought he has a hearing loss, but an audiometry done and was normal. Teacher is also noted has occasionally starting spell and brief seizures. On examination, the child is alert, cooperative, but shows severe language regression. Severe language regression. Neurological examination otherwise is unremarkable, and EEG show a frequent spike over the temporal region, especially during sleep. So, another few seconds for you. Yes, it is Landau-Kleffner syndrome. Landau-Kleffner syndrome is coming around 3 to 8 years old, and the feature is very, very characteristic and pathognomonic, and is the only one we have a language regression. Language regression in a previously normal child, an EEG temporal spike variable, temporal spike, and temporal spikes I will show you in the next slide, and language regression in Landau-Kleffner. You should memorize it. Treatment we can treat by steroid, valproate, and speech therapy. One causes when the cause is unknown, give cortisone. Okay, it's an old ancient sentence in medicine in Egypt before. Steroid and valproate speech therapy. Mnemonic Landau-Kleffner language lost for Landau-Kleffner syndrome. Okay, I hope I'm clear for this one. And so we will go for the last specific epilepsy case. A 7-year-old previously healthy boy brought it to an emergency department at night after he has unusual episode during sleep. His mother described that he suddenly sat up in the bed and looked pale and began vomiting repeatedly. Okay, I hope I'm clear. So suddenly he sat up in the bed and looked pale and began to vomit many times. Shortly after, his eye deviated on one side and he became unresponsive, and the event lasted for about 15 to 20 minutes. It's a very long period. After which he was drowsy and slept for several hours. On arrival, the child is fully alert and febrile, and he has his neurological examination is normal, and there is no family history of epilepsy. So, what do you think? Yes. So, our case is self-limited epilepsy with autonomic seizures, SELEAS, which is a newer name for it. Self-limited epilepsy with autonomic seizures. It's coming in school age. It is not very common, but it is for your knowledge. At the school age, it is coming with autonomic features like pallor and vomiting and papillary change and cardiorespiratory symptoms, and it is only one coming with autonomic seizures. Occur especially at night or during sleep, that the child is wake up and sit down or starting to vomit many time. It could be prolonged. I told you it's about 20 to 30 minutes, which looks like status epilepticus like, but it is a benign one. And EEG, when you are asking about EEG, it is a multifocal, often occipital predominance that can shift later. Prognosis and excellent, and it remits by adolescence. Nothing at all. And it is a self-limited epilepsy. Self-limited epilepsy, nothing to be done with it. How does it differ from febrile seizure and acute gastroenteritis? Febrile seizure require fever and usually generalized, and the gastroenteritis associated with the maybe usually associated with diarrhea, and there is no ictal eye deviation or change or altered awareness. An EEG, high amplitude multifocal sharp wave and occipital region, which is the first time in our specific epilepsy we have an occipital region enhanced sleep. Management, no daily anti-epileptic drug are needed, and treated prolonged seizure acutely. Treat prolonged seizure rectal diazepam as any kind of seizure we are treating with rectal diazepam or buccal midazolam, and reassurance you have to make assurance of the parents it is a self-limiting with remission by adolescence. Okay, so I make a small table for you to remember what is the management of a treatment for each one. Just this slide to be memorized before exam or to be revised only during before all the time, and especially before exam. Absent seizure, isoxamide, don't forget, or a sodium valproate. Absent seizures, isoxamide or sodium valproate, and you have to avoid the carbamazepine. West syndrome, vigabatrin or steroid according to the etiology, and we will explain later on. And Lennox-Gastaut, lamotrigine, and often resistant and require Lennox-Gastaut L for language delay, and even resistant and need or require multi-drug therapy. Benign neurologic epilepsy, it is a benign condition, nothing be needed, and use carbamazepine if interfering with daily activity. Juvenile myoclonic epilepsy, sodium valproate or lamotrigine, and don't forget it is a dropping attack, lifelong medication or treatment is needed. Carbamazepine is contraindicated and coming in MCQs. Okay, and this is AEG pattern with syndrome, hips arrhythmia, Lennox-Gastaut absence, just to be memorized. It is tailored for a quick revision before exam, and this is a timeline teaching and age of onset of everyone to quick comparison for you. And don't undo Lonix 2. You should avoid the carbamazepine. Absence seizure, also you should avoid the carbamazepine or phenytoin. Also juvenile myoclonic epilepsy, you have to avoid the carbamazepine. And the neurologic epilepsy, what should we do and what we shouldn't do. And here, if you would like to more detail regarding age syndrome and how can you differentiate between age syndrome, like age and features and EEG pattern and a comparison, quick comparison, so you can study from here to easily make a comparison and differentiate between a different type with syndrome, salam attack, developmental regression, and even causes idiopathic tuberous sclerosis and prenatal or subdural hematoma, which is a different causes, developmental regression, hips arrhythmia, chaotic high amplitude multifocal spikes, and also Lennox Gastaut, multiple seizures, 1 to 3 year dropping attack, intellectual disability, slow wave, uh, and here again, sorry, this is a slide done to time. The remaining one here, this is an absence epilepsy, juvenile myoclonic epilepsy, and benign Ronaldic epilepsy, Landau-Kleffner, each features of each one. Okay, and how can you differentiate? You can make two put together all together so you can memorize it well. Centrotemporal spike, you have an extra or very little word, it will be in addition to our cases. So if you go for in depth for pathophysiology and why epilepsy happen, this is arises from hyperexcitable neural network. It could be abnormal or electrical discharge. Abnormal electrical discharge could be due to genetic abnormality, an ion channel neurotransmitter defect. It could be structure or cortical abnormality or other metabolic or immune dysfunction. And if you would like to classify our causes so we can easily memorize it, it could be idiopathic A, B, C, D. A, idiopathic, presumed genetic, no other structure or metabolic cause. Structure like a cortical dysplasia, tumor, trauma, stroke, infection. It could be happen. It could be due to metabolic hypoglycemia, hyponatremia, hypocalcemia, or inborn error of metabolism. It could be due to genetic strong family history like a juvenile myoclonic epilepsy or absence epilepsy, or it could be drug-induced iatrogenic, drug-induced of withdrawal symptoms of some medication, toxicity of other medication, or it could be some autoimmune disease which is not commonly, but sometime it should be mentioned. This is a neuroimmunological association in neuropsychiatric lupus, seizures with mood swings, and rash, cytopenia, and you can go and find it only in the past test question, which is not common in other area or other on examination. I think is not mentioning this neuropsychiatric lupus and neuromyelitis optica, optic neuritis and myelitis and seizure and other autoimmune encephalitis. Management, how can you management of the case of epilepsy? So I think it is an emergency situation, and the first thing to be done, you have to stabilize the patient through ABCDE protocol, acute stabilize airway, breathing and circulation, and stop the seizure by giving benzodiazepine, and you have to follow up with neurology and to take antiepileptic drug and tailored to the type, which type according to type, take levetiracetam or valproate, and treating underlying cause if available, like a correct metabolic condition or surgery for a tumor or a lesion, and immunotherapy if it is autoimmune related, like steroid or if IVIG, plasmapheresis, or biological treatment for autoimmune related epilepsy. Support if you have to make family counseling and neuro developmental follow-up. Okay, so summary for our session: epilepsy is a recurrent unprovoked seizures. It causes idiopathic structure, metabolic, genetic, iatrogenic, autoimmune, and pathophysiology hyperexcitable neuronal network, and AED management address the immunotherapy or whatever treatment of underlying cause. And this is our common epilepsy, like tonic clonic, generalized tonic clonic. We are using sodium valproate, and you have to know it. Also, by the way, the complication of anti-epileptic drug, it is very important, and you have to know by your heart. And second line, we are lamotrigine and topiramate, absence ethoxamide and sodium valproate. And do not forget, I'm trying to change my tone just to make it little memorizable for you. Absence seizure for ethoxamide or sodium valproate, and also second line lamotrigine on almost everyone. Myoclonic epilepsy, sodium valproate. I told the with the generalized tonic clonic one, topiramate and levetiracetam, and the second line lamotrigine. Focal epilepsy, it could use for carbamazepine, sodium valproate, and topiramate. A special note: if you the infantile spasm or Swiss syndrome, if it is related to tuberous sclerosis, we should take or treat it with vigabatrin. Vigabatrin, don't forget it. If not related to TSH, to tuberous sclerosis, we are giving ACTH. Okay, and to memorize, it's coming more common, especially in the past test examination. Cluster seizures, it is another MCQ tip. Cluster seizures worsen by other condition, like a menstrual cluster seizures, which is a seizures worsened by another condition like menstrual cycles. Clobazimab is a treatment for this one. I hope I'm clear. I can provide you with illustrative short uh, uh, one for the special type of epilepsy. Thank you. I appreciate it.